Hello, everyone. Thank you for joining us for Let's Talk About Cancer. Today we have Dr. Celina Valencia, who is an NIH T32 postdoctoral fellow at the University of Arizona campus. Thank you for joining us, Dr. Valencia. Do you mind introducing yourself?
Sure. Thank you for having me, everyone. It's a pleasure to be here. I am Dr. Celina Valencia. I am a postdoctoral fellow in our National Institute of Health T32 training grant at the Cancer Center in Cancer Disparities. Yeah, and that's who I am.
Should I introduce myself? My name is Octavio. Hi, everybody. I'm a health educator with the COE team here in Tucson. Yeah, that's a bit about me. I'm excited to talk about breast cancer today.
So what do you do at the Cancer Center?
So as I said, I'm a postdoctoral fellow. We're very fortunate to have a T32 here at the Cancer Center, and I'm very honored for the opportunity to be here. I'm specifically interested in breast cancer mortality disparities among Latina populations. So what that means is I'm interested in the period of when the woman finishes treatment to 5 years post treatment. That's a very sort of golden time. It's how we measure mortality success. And so that's what I'm doing. I'm doing some focused training in cancer epidemiology, but also in data science. So I use a data science approach to answer my questions. And that's what I do at the Cancer Center. So I play with numbers.
I wanted to ask, what is a T32 scholar? Just because I don't know, I feel like it would be good to give everybody a little background.
Sure. So like I said, it's a National Institute of Health training grant. So the NIH awards various training grants that the institutions, universities apply for, and it's devoted specifically to training. So our thematic for this training grant is cancer disparities. So it's cool for to know about these T32s because you can participate them as pre-doctoral fellows. So that means when you are in graduate school, you are working towards your PhD or your doctorate, there are T32 opportunities. This is not one of those grants. So this one is also from the National Cancer Institute, and this is only for people who have already gotten their doctorate. So for this training grant here in Cancer Disparities, there are 4 fellows, and typically you have a 2-year appointment. Things are a little weird with COVID right now, so some people are extending their appointments, but you do focus training and you kind of become this like expert plus in cancer disparities. So each one of us have a different focus, and you just kind of get a little like boost to all the training you received as a PhD student.
That's great. So it kind of creates this pipeline that everybody can get experience and then come out of that with like a research question or something.
Yeah, I mean, hopefully, yes. So it's just a way, because I mean, I think that's part of what you do when you're getting your PhD, right? You find your research path, you find your passions, but then you use the 2 years as a postdoc as a very sort of protected and golden time to get very focused and very refined in the skill set that you're going to train in those 2 years. So then the goal is to become a faculty member, or to leave that postdoc is like this very like technical, narrowly trained expert in what you did during your postdoc.
Gotcha.
Yeah.
So Desiree, is that something that you're gonna do? Because Desiree is getting her doctorate in public health as we
speak. Yes, Desiree's gonna do a postdoc and then be faculty. I see it in my crystal ball. Yay, that's exciting. Congratulations.
Thank you. Yeah, so what kind of research are you currently doing as a postdoc?
So again, like I said, I focus in on mortality disparities, right, of Latinx populations. So I do big data inquiries. So I use the Surveillance, Epidemiology, and End Results database, which is a national level set of data that is collected by various states, and it all kind of flows into the National Institute of Health. So I'm using that data set to better understand what are the mechanisms and factors that are happening in the lives of Latinas post-treatment and in those 5 years, right? So is there an age issue? Is it like a geographical issue? So I'm using that national data to get a better understanding of that. I also do secondary data analysis on Arizona Cancer Registry. So that's more local, that's run by the Arizona Department of Health Services that holds all of that. So it's all of our cancer patients that are in the state of Arizona, where breast cancer continues to be the leading cancer experienced by Latinx and American Indian populations in our state. So yeah, so that's what I do. I use epidemiology methods to approach those big data sets to get a more granular understanding of what are the factors that are causing this mortality disparity in those 5 years post-treatment and diagnosis, in order for us to get better sort of knowledge, or we can kind of point out the factors that would be good for interventions in order to kind of work to for equity in mortality in Latino populations. Yeah.
So yeah, that was my question. It was going to be kind of what is the research showing? So is that what it is, that there is a disparity in the women, the Latina women that die from breast cancer die more often or at a higher rate than other women
Yes.
in general?
Yeah.
Or is it just non-Hispanic white women? Just all women?
Yeah, no. So non-Hispanic white women, they die less. Their rate is smaller for death from the 5 years from treatment to diagnosis than you would see among Latinas, than you would see among African American women, that you would see among American Indian populations. So that's why we call it a disparity. So the question that I'm asking is, so what is going on in white populations that's not being reflected in these other populations, that we're not seeing them have successful survival rates at the same pace, right? So that's what we're looking at. So yes, so that's where the disparity exists. That if you are a white woman and you have breast cancer, you are more likely to make it to that golden 6th year than you would in these other populations. And so the question is what? I'm trained specifically in social determinants of health. So that is just for, so we can all make sure we have the same operational definition. So that means I'm just really interested in the social lives that people lead, right? Like I'm interested in, did the person have healthcare? Did the person have the health literacy to know, about their treatment, or about the expectations of, what the physician told them they needed to do? Did they have the resources to ask for a mastectomy or versus a lumpectomy? And could those various factors, or the type of health insurance that people have, could those various factors be what's influencing this mortality disparity, right? So that's what I'm looking at when I'm saying, okay, so we know that this disparity exists. We know the rate of survival is different, but what is going on in the lives of these women that could be pushing this? Is it the provider? Is it the insurance? Is it their geographic location? And on and is it family history? Is it lack of, is it lack of, we find that there is a disparity in the women that receive, genetic risk assessment. So that means you go to a doctor
that know about that
know to ask about that, right? Or go in and ask, and then they get told it's unnecessary, right? Even though the for whatever reason. But another really interesting thing about BRCA testing and the genetic testing is not a lot of physicians are interested in it, right? So if it's not an interest of the physician, they don't recommend it to the patient, right? So
or it's a billing thing. It could be a healthcare system issue.
Yeah, it could be a broad systems issue. There could also be, like among Latinas, there's also a body of literature that talks about how Latina women will get their, first of all, they're less likely to get mammographies, right? So that is something that we're dealing with screening. And, you know, is it a lack of like knowledge? Is it a provider institutional distrust? Is it, you know, just various things like what is going on that the mammography rates are low? But also there's also this body of literature that talks about cancer fatalism and this concept of I may have this diagnosis for cancer, but I'm going to give it to God. You know, I'm going to let my faith and my religious views drive what happens to me. And so that's another element that we have seen in the breast cancer Latina literature as a possibility. And that would be very much a social factor, right? Because the women also
But my question would be, do people really feel that? Or is that something racist that someone made up that they think is happening? You know what I mean?
Well, think about the Latina women in
We'd
your
have to
life.
look at the research, yeah.
Well, no, but just think about it like qualitatively. Let's think about the women in Latina women in your community, in your life. I know in my life, I have people that are old school Catholic and they will say like, it's up to God, right? But then there's also this element of, but I also like God helps those that help themselves, right?
Yes.
And I think both of those things are captured in the literature. But just so let me bring that question back to you. I mean, could you say that you could see that going on in your community?
Yeah, absolutely.
Yeah, but I mean, that is a good question. Like, who is writing these articles and what is the bias there? Absolutely.
But, so yeah, that's to say that there was probably a lot of different opinions or answers that people have as to why this disparity exists, but why do you think, or what have you kind of seen in your career and your studies that where do you land on this?
Me personally, where do I land on this cancer fatalism?
Yes. And this the mortality disparity, like why are Latinas dying more?
Right. So I think that it is this intersection of, I think that there are, so it's this, okay, so it's this intersection of, I think that there is a lot of biosocial factors. So that means sometimes the stresses that we experience in our lives have physiological implications, right? They lead us to be more inflamed. We have different stress biomarkers floating around in our blood, and that could influence the treatment efficacy. It could influence how aggressive the cancer can operationalize in our bodies, right? So I think that that is part of it. So this like context, right? Like this context of stress and this context of cumulative stress across the life course. I think that is something that is a salient consideration for Black women, American Indian women, and also Latinas, right? So that to me is sort of this like core mechanism that you would see in these three populations that maybe you wouldn't see as much in non-Hispanic white women, right? So I think that is a factor that we have to consider. But I also think that there is this intersection of the lives that we lead as Latinx folks, right? So I think one example is I have had family members with cancer. I am from a rural border town, and they will go into Mexico to get treatment instead, which is fine. But then that means like we are losing our data in the United States for those folks that cross over. And I'm not saying that that's like huge numbers, or maybe it is. We don't have enough data on that to, I can't really like speak to that. But also I've also seen like my family members say that they believe chemotherapy is not the best avenue for treatment. So they're going to use herbs, they're going to use like holistic methods, they're going to use these remedies. And those are the things that they're going to pursue versus going to traditional Western spaces. But that goes back to the social lives that we lead. And maybe that's a degree away from saying, I'm just going to give it to God and not get chemo. But I mean, it's in the same, like, you know, it's in the little same constellation there. So yeah, so I think those are all salient considerations for what may be going on.
Great. That's a good explanation. I wanted to know, with the data that you have been doing, what sort of trends are you seeing right now with the data that you're using?
So the data that I'm using is that there is a difference in time of diagnosis to treatment. So that means there is a difference between when a Latina will receive a diagnosis and when they will receive their first treatment. So since this is all quantitative, I don't have more than the numbers. So I don't know what is going on qualitatively in this capacity. I don't know if it's that there's no health insurance. So I don't know those elements, but I know that there is this sort of lag between diagnosis to treatment. I also know that the data indicates that if you are in a rural environment, you are more likely to get a different treatment recommendation. Meaning that if you are in an urban setting, you're more likely to receive like a lumpectomy and radiation. And if you are in a rural setting, you're more likely to get a mastectomy. I mean, I'm not a physician, right? But there is some discussion about which way is more effective treatment and which way, so that's interesting in that just where you live and what the provider recommends is different. We also know that obesity is a factor among Latina breast cancer survivors and body mass index. And that's present in the data and the analysis that I've been doing, but the role that plays, I'm not sure. Because again, that could be larger contextual issues going on. Is it obesity or is it, obesity as a byproduct of stress and inflammation? And that could be a factor in the cancer. So there's a lot. So, I'm just starting my career. I have some time. And so these are interesting findings, but those are things that are going on in the data. So there is some treatment issues, health insurance coverage issues, but also Latinas are more likely to get a diagnosis later at a later stage cancer, meaning, and that goes back to the point I made about mammographies. So where they kind of lost a window of early treatment, they might be have already a more, a different type, a more advanced cancer. And then the other thing is they also are more likely to have a more aggressive type of cancer. So we see more triple negative breast cancer in this population of women as well. So that's sort of what the data is telling me. And, we have to think about the next steps and like the next studies to get more information on that.
We had some questions in the chat. I think this was going to your question, your comments about providers and the types of care. So one of the questions was, have you thought about including stereotypes in this analysis? So an example is a First Nation Indigenous woman died in the hospital due to the care she received. The staff did not listen to her, only treating her based on the stereotype of Indigenous people drink too much alcohol.
So I want to start by saying that is horrible. And I'm sorry to hear that that even happened. I think that unfortunately that may happen more than we know. However, I'm not, I have an interest in that work, but because I just use quantitative data sets, that's not something that's in the data that I review. But I think it should be. And I think that that would be great if we could sort of integrate more of those questions about physician bias, or there's also some talk about bias in terms of people who are obese. So, or, overweight, that they go in and they kind of just get waved off when it was an opportunity for screening and treatment of cancer because they're told you're just overweight, go lose some weight. So that's another bias that's present in the literature. But unfortunately, the type of research I do, those NIH data sets and like the Arizona Cancer Registry data sets don't have much of that qualitative experience around bias or racism or stereotypical, problems that impede the quality of treatment that the women receive. But I would love to get a grant that kind of asks those questions because they're very important.
Awesome. And then we had a second question, was if the Affordable Care Act is repealed, how do you feel that this would impact your research in 5+ years, Latinas acquiring the healthcare necessity to screen, treat their cancer?
So the Affordable Care Act is really interesting because even though this is in place, Latinos are still unlikely to be insured. So the Affordable Care Act doesn't do enough for this population. It's not clear as to why. But I think that if we could connect Latinas to care in a better way, that would definitely have it would have lasting impacts, and it definitely would influence the 5-year mortality outcomes that we see if Latinas were able to get early screening, get treatment that's meets their needs, and
Oh, no worries. The struggles of Zoom continue. We totally understand.
sorry, I have a little one,
It
and
happens, no worries.
yeah, 2020, yay.
We know, yeah.
Thanks for
Doesn't
understanding.
use this anymore. We don't
Yeah.
even.
Thank you.
Just
So
kids
yeah, so
running
the
across
Affordable
the
Care
screen.
Act, yeah, running the show. So the Affordable Care Act is really interesting, like I said, because while it's in place, it's still Latinos are not being insured at the same rate as other populations. There's some hypotheses as to why that's going on around, institutional distrust, or or mixed status families, meaning families that, while one person might be eligible for Medicaid or Medicare, there's a fear because they have someone in their family that is undocumented. And so they're less likely to be enrolled because of fears about their extended family. Yeah, so I'm not sure how the Affordable Care, so if the Affordable Care Act is repealed, I'm not sure what the influence would be, because we're seeing these sort of low enrollment rates in health insurance as it is.
And yeah, I think what these questions get at is something that I've been kind of thinking about, which is this idea of like decolonizing your own thoughts, your own approach to what the issue that presents is, right? So when we're asking like, what is causing this? Sometimes I feel like, well, who are we comparing it to? And oftentimes it's a straight white male, and we're saying that's the standard. So how does this deviate? I mean, for breast cancer, obviously it's way different, but I think there's something to that. Like, what are we bringing in terms of our own bias when we think about these things? So what I think, in my opinion, of what's going on with breast cancer and Latinas, as someone who only has a bachelor's degree and as an English major, but I think it's trauma. I think there's something about trauma and the history of what has happened, particularly in the Southwest, same with the Native American population that experienced genocide, really. And so that history and the lack of access to healthcare combined with the social, economic barriers and the trauma, I think that all has something that's going on, and the epigenetic research and all that stuff I find very interesting. I think there's something there, but I don't know. What do you think? And hi, Ellie. She steals the show every time.
Hi, Ellie. I'm so okay. I'm not sure I captured the question. So you're asking me about the social
What role do you
determinants, and
think
if
trauma
oh.
and like historical trauma, like what has happened to Mexican women in this country, in the Southwest, Native women as well throughout the country, um, and how that might be affecting them now in terms of breast cancer death.
Yeah, so I absolutely think that, like I said earlier, I think biosocial stress is absolutely a factor. Do we know that biosocial outcomes are transferred through through epigenetic mechanisms to offspring? Absolutely. Do we know that social stress and stressors from life adversity in childhood and adulthood influence DNA methylation? Absolutely. So we do know those things, but we need more research, right? We need more research to get into, is the trauma of being, of living your life and receiving a cancer diagnosis enough to cause some epigenetic consequences that could influence that mortality across the 5 years? We don't know. This is really funny because I was actually trying to find a paper on this and there isn't one. So it's a good area of research. Do I think it is plausible that that could be a driver? Absolutely. Do we have the data to support that? Not currently, but I hope that it is something that we can see soon. But I also don't want to sort of shove the burden all on epigenetics and genetics, because I want to say that the lived experiences is incredibly important, right? And the so not just intergenerational transference of biosocial outcomes, but also, what we're facing now, right? Like, are there impacts physiologically of your neighborhood being raided by ICE? Absolutely. Is there, physiological consequences of, fearing that there is like a pop-up ICE checkpoint? Absolutely. And does that influence undocumented Latinos as well as documented? I believe it does, right? We do have some literature that indicates it does, that it influences the entire community. And does that impact? So that has impacts, but also the ways in which you approach a physician, and the type of care that you have access to, and the type of insurance that you have access to, and what that will allow you to get in terms of treatment. I think those are also very important to highlight, and not just say that these are, it's, just epigenetic, right? Or it's just these sort of like traits that you inherited and carry with you, but it's also the lived experiences of these women that are very important considerations as to what's happening in that 5-year span of time.
It's just everything. It's just all these things. Yeah, we can't
It's a constellation.
simplify it. Yeah. It's multitudes.
Mm-hmm.
Ellie, your turn.
I'm gonna combine these two questions that I had. So a lot of your work has been predominantly in Latina communities. So what inspired you to focus on that population? How is health equity important in that? And also, how did you get interested in doing health equity work?
Okay, so I am myself a Latina, right? So I'm a Latina from a rural border community, as I've mentioned. And so from a very young age, I saw that if anyone got sick, you didn't go to the doctor, right? You kind of figured that you went to the curandera down the street, or you crossed into Mexico, and these are very different responses to health and health outcomes, right? So it's a bit of a lived experience. But then once I started, and I saw that we had to come to Tucson, right? So if you had, I don't know, so you came to Tucson to see doctors, and there wasn't a lot of availability for the same sorts of things. So if you got cancer, you had to come to Tucson and stuff like that. But and it made me wonder, does everybody operate like that? So, and what are those differences, and how could those affect health equity? So a lot of it does come from my own lived experiences. And then I think health equity is important because I think having good health is a human right. And I think that having access to a physician is a human right. And so for me, the question becomes, so how do we, as a collective society, how can we make that happen, right? How can we make it that everybody has the chance to have their best health and live their best health, to live to be 100 years old? Like, what are the steps that we have to take? So that's why I focus on health equity. My doctorate is focused on policy because I'm really interested in, the promise of the Affordable Care Act. So if you open insurance to as many people as possible, that's wonderful. But then so then the question becomes, so what's causing those gaps that Latinos continue to be not enrolling, even though the Affordable Care Act is in place? And so what are those social questions, and what are those social actions that we have to take in order to build a country where people can all live to be 90, or the majority of people can live to be 90? Because as Octavio pointed out, there are epigenetic and genetic issues, but let's just maximize the number of people that can live their best lives, and that's kind of why I do the work that I do.
Great, thank you. I'm also in the policy program, and I never realized how important policy was in the social determinants of health and the health equity of populations. And then you start to get into the weeds of why, how policy is important, and I think it's an underestimated part of politics. And yeah, being in my program, you see so many things that frustrate me, and you're like, but how do we go about fixing it, is like the common question of like, how do we ensure that everyone gets equal care? And yeah, it's a thing.
So I think one thing we haven't talked a whole bunch about, but I find to be very interesting in terms of the mortality and social determinants of health is, so one sort of hallmark of recommendation that people receive is exercise, right? Make sure you get your physical activity during your treatment, but also after your treatment. And make sure that you're eating your colors of vegetables and fruits, right? But what does that look like in a neighborhood that's a food desert, right? And how do we link people, right, from that are residing in food deserts that maybe don't have access to produce? And so one thing to think about is policy can influence that by changing zoning laws, or requiring like that these food deserts have these spaces that provide produce. Or if you think about Tucson, not every neighborhood has sidewalks, right? So because a really easy physical activity that people always say is like, oh, just go for a walk, or but not every place has sidewalks or spaces to just like walk out your front door and do that. But how can you change that with policy, right? You can get the policies in place or work towards them. So I think that that's where policy becomes very important in thinking about how you can change people's context in order to give them the tools to meet the recommendations of physicians, or to maximize their treatment. So that's another, I think, important shout out to policy and the power that it holds.
Yeah, absolutely. Like this presentation I saw a couple weeks ago, the Office of Health Sciences, Office of Equity, Diversity, and Inclusion. There's this program. So Pima County has the Loop, right? And it goes all around Tucson, and it's there for everybody, but not everybody knows about it. And so there's this program called Reach the Loop, to try as a cancer prevention, to try to get more people to be active and using the Loop. And so there was this whole outreach, and families were like, yeah, that's great, but it's unsafe. There's like people there, and how are we going to send our children to start? And so then the neighborhood started meeting, and they started basically like a crossing guard type of volunteer. So now it's safe, and there is like this effort to make that space safe for everybody, because that's what it's for. And it's not just for the cyclists that do El Tour de Tucson, it's for everyone. So outreach and things like this, and letting people know that that's what stuff is there for and can help. But that makes me think of Mariposa Community Health Center. And I heard that you were doing some work with them. Could you talk a little bit about that? Because they are great, and I always want to put a plug for the good folks down on Mariposa Community Health Center.
So I am a big fan of Mariposa. I'm not doing work there. I would love to, but I know that they have wonderful programs there for breast cancer. They have a very active breast cancer group down there, and yeah, shout out to Mariposa, like,
and just the community health workers in general.
Yeah, God bless the promotoras. Also,
Yes.
like the cancer navigators that are part of the Affordable Care Act, right? Yeah,
Yes,
these are
yes, exactly.
powerful resources, right? And yeah, they're amazing. I'm working on it. I don't have anything to report today. I wish I did, but yeah, big ups to Mariposa for sure.
Yes, in terms of lifestyle things that we can do, and to advocate for, like sidewalks in our neighborhoods and safer parks and all that good stuff.
Yeah, like I like to say that it really, so I, as part of the data science approach that I take, and what I'm moving towards is looking at social networks, because I really do think it takes a village to have like a successful time after cancer, right? It takes a village to get it done. And I think Mariposa is really good at being the real life version of that, right? Like that there is a village at Mariposa Clinic that you can lock into, and they have great outcomes because of it. And it's amazing. Yeah.
And yeah, that support, that connection of who is gonna keep you motivated to come going to that group about nutrition and diabetes or whatever. I saw that firsthand, that people are just so holding each other accountable, and that's great.
Yeah, it is. It's very powerful.
It is community.
Yeah, yep. I do agree.
So with the health disparities, what about clinical trials? Why is it important to include Latinos in clinical trials, do outreach so that they know about clinical trials?
Yeah, so okay, so I'm gonna put on my scientist hat, right? And I'm gonna say, so for good science, we want the clinical trial participant population, the subjects, to match our bigger society. So the things that we find are generalizable and right. So
you want a good sample size. You want the pool.
Absolutely.
To
right.
encompass everyone.
Yeah. So that's my, that's the scientist hat. But the other thing is, so I think a really good example is heart attacks, right? So I know that's not cancer, but breast cancer does lead to cardiovascular complications. So kind of, right? We're kind of in the same house, but there's a link. But so what I was going to say is, so heart attack symptoms among men, which were heavily studied, everywhere, if your left arm is numb, these are your hallmarks of a heart attack. It doesn't look like that for women, right? And so there are differences in the symptoms. There's differences in the ways that the drugs will work across your age, across your gender, across race and ethnicity. And that's why it's important for this diversity of participants in clinical trials. In order for the treatment to not just work for one group of people, but for a spectrum of people, right, across the population. That's what we should be striving towards. And so not only is it good science, but it's just good for health equity, that if we know that those medications or whatever's in their clinical trial, because clinical trials also encompass behavioral trials, right? Like, do promotoras help prevent future complications, right? So there's also clinical trials that are behavioral, but culture will impact those behavioral clinical trials as well. So that is, for me, why it's important to have a diversity of clinical trials and to really make that effort to do the recruiting and the participants, and so that we can, I think it's a bridge to health equity, because the treatments and the behavioral interventions will be more effective if we have a diverse group of participants in the trial.
Yes, I completely agree. What I always say is, when we cure cancer, which I'm promising a cure, we want to make sure that it's for everybody, not just one group of people.
Yep.
We had another question coming through the chat. Do you think that there needs to be institutional change for policies to benefit a community?
So I think that the institutional change does come from policy change, right? So the policy will change the institution. But right, you do have to have that institution willing to make the policy change, right? So the arrow is a bit bidirectional, it goes both ways. So I do think that, but I also think that an element that is interesting to policy change is there's also an element of behavioral change that's required. So I believe this is the same person that asked about the Affordable Care Act. And so I'll bring us back there. So that was a policy that was implemented and enacted, and we've had it for, you know, quite some time now, but we haven't seen that behavioral change of Latinx folks getting enrolled. So I think that I don't think it just needs to be an institutional change. I think it needs to be a systemic change that needs to really be put in place for policies to be the effective driver of change that we would like to see, especially for health equity. And I think the Affordable Care Act is a great example of that for this community, that what is that element that's missing, that is that gap between insurance enrollment and participation in the Affordable Care Act when it's a policy that's in place.
Yeah, because that's when the screenings happen, right? You need to have your insurance to be able to be going to those preventative appointments with your primary care provider, even if it's a different primary care each time. But having those, you know, timely sessions where you can kind of get a heads up, like, hey, next year, we're going to talk about scheduling this colonoscopy or this mammogram. And you can't do that if you don't have health insurance, or if you're worried about just making that payment for that one visit that you can afford.
Absolutely.
Absolutely. And they say thank you, double exclamation.
Yeah, you're totally welcome. Thank you for the question.
I had to turn off my camera, but so what do you think there, or not do you think, but are there some key considerations when working with Latina population?
Yeah, absolutely. What kind of work are we talking about? I mean, I think that the most important thing when doing any sort of community research or community-based research is that they have to be viewed as partners and collaborators, and they have to be respected, right? Their lived experiences need to be respected. We need to sort of do the work to minimize our own bias, right? Not just if we are from a different cultural background or race and ethnicity, but also if you know, just because I have a doctorate, I'm not an expert in the community. And they're like, you know, I acknowledge that. And so that's another bias that you kind of have to check before you work with the population, is you have to say, I know what, you know, I know the positionality that I hold, but that does not make me the expert on everything. And so I think that's one of the things, is to really respect and acknowledge that you know, your biases and their expertise, and also considering how they're, so I think like a good example is I went into a rural community to work with their youth, and I had a very specific sort of vision of what we were going to bring to the community. But then I got to the community and the parents were like, no, we don't need any of that. Like, what we need is you to talk to them about obesity and like physical health. We don't need you talking to them about this or that. And so I think that part of the importance of those conversations is that I, as a scientist, might have my ideas, but you have to kind of listen to the community, and you have to kind of make the steps. So you're really reaching them, and you're working with them, and you make those changes. So I think those are sort of the key elements, right? Is to check your bias, build your relationships, and just make sure that you really view them as the experts they are of their own lived experiences and in their communities.
I agree that bias is a huge one.
Yeah.
And that we all have them. Like mine is that trauma causes everything, like I said earlier,
Yeah.
So that's just because that's my bias, that's my background. I was a social worker, so I just see trauma in everything. It's like, oh, you're just talking because you're hurt. That's where you're speaking from. And so I see that everywhere, and that's not necessarily true, but it's important to acknowledge that. And I think that's what you're saying, that there's bias. And it's important to find that within yourself and know that it exists, because knowing is half the battle. You don't have to beat yourself up about it, but acknowledge it and know that that could cause you to, like I did in our conversation, I jumped and said that someone is racist because they think that a Mexican would rather pray to God instead of go to the doctor, when it's like, well, hang on, that maybe that's your bias speaking.
Yeah, but it's complex, no?
Yeah.
But also, no, I think that is a super good point, and I think that also we have to value the resilience of these communities, right? And that there is trauma, but there are, it's not a deficit model. These are rich communities with tons of assets, and I think that needs to be acknowledged as well. So that's sort of the other side of that trauma coin, that the trauma does exist, but so that's kind of, brings us back to a couple of statements ago when we were talking about epigenetics, and that is a consideration, but you have to also acknowledge the assets and the resilience and the communities that they build, and their ways that they leverage resources in contexts where it's not a ton of resources, but they make a way, and that's amazing. And I think that is also an important consideration. I just don't want us to go away, keep pointing at these deficits, when we really have to also say, there is a ton of assets that go with the trauma, right? And there's a ton of resilience, and I think that that's important for health, and I think that's important for the communities that we build to build more health. So I just want to make sure that we insert that into the conversation.
Yeah,
right?
no, it's a positive.
Coin is community and resilience. Yeah.
And I think that's where we're at in the timeline. I'm seeing positive. I'm seeing equity as a word just being used more. I'm seeing a shift.
Yeah.
There's positive things.
Yeah, I think so COVID, right? COVID is very 2020. But I think one of the really fascinating things about community that is coming out of COVID is the groups of mutual support. I don't know if you're aware of those, but especially in New York City and stuff, where they built food pantries, and they were figuring out these ways,
shopping for elderly neighbors that should not be in a grocery store
or a high risk. Yeah, absolutely. But I think that that's just a fascinating extension of
it's a return to how we used to live. I think it's more smaller groups and more all right, you're gonna be the baker, I'm gonna be the hunter, and we're gonna cook dinner together.
Yeah. And if you measure that, right? And if you measure that for health science, to say okay, so people that are elderly and high risk and couldn't get to a grocery store, but they were getting groceries because of mutual support, and does that have health impacts and outcomes? Absolutely it would. So just thinking about the ways in which we kind of move and live our lives. Yeah.
Great, we're almost at the top of the hour, and I wanted to end or we'll open up for questions, but I wanted to ask, where would you like to see yourself in your career in cancer after your postdoc?
So I would like to be a faculty member, right? So the 10-year goal is to be sort of an NIH funded faculty. I would love to remain at a Hispanic serving institution in the Southwest, because I would like to continue my research on Latinx populations. So that's the 10-year goal, right? To be tenured as a faculty, to be doing this work, to continue to mentor graduate students, So that's like the goal and moving towards, and it would be wonderful if we could in these next sort of 10 years identify, if we could identify one mechanism in my research to kind of help with the mortality disparity, that would be like beyond amazing. That's the career goal, right? To figure out and influence one of these mechanisms that may be causing early mortality in Latina breast cancer patients.
So I'm going to open it up for any other questions that the audience may have. Okay. While we wait for any other additional questions, thank you, Dr. Valencia, for joining us today. We really enjoyed this talk about Latino breast cancer mortality and health equity. So thank you.
Yes, thank you
Thanks
so
for having
much.
me. It's been a lot of fun.
For the upcoming events, we are having a mask donation drive for the Tohono Nation and Pasco Yaqui tribe every Saturday, November 7th and November 14th. We will be accepting donations for cloth masks or masks in general at the U of A Cancer Center. And so if you would like to donate, we'll certainly provide more information on our social medias, but just letting people know that we are having a mass donation drive in the coming weeks. And
Oh, everyone, please fill out an evaluation on RedCap. It will let us know how we did, what to include, what to add, but also it will enter you for a prize or for a chance to win a prize, which our drawing is going to be this Friday. Yay! So your chance to win a very cool water bottle. And can we also enter? I don't know if I've asked that question before, but I might fill one out. Just worth a shot. Could always use an extra water bottle, but thank you so much, Dr. Valencia. This was a great chat, a lot of awesome information. Anybody can rewatch us on the recording. It's going to be on our Twitter, our social media is down there. Please follow us, rewatch, send to anybody that you think would be interested, and then have them fill out an evaluation and they can enter to win a prize. So I think that's it. Thank you so much. Muchísimas gracias.
A ustedes. Gracias por invitar. Bye, everyone.
Goodbye, everybody. Thank you so much.